And I want patients to know that in regards to genicular artery embolization, this is about reduction of pain, not elimination of pain.
I don't think it's going to put me out of business. I'm all for something that would put me out of business.
I like to call it just pruning of the blood vessels.
Hello and welcome back to the channel. This episode's a little different. The other day I got a text from one of my partners, and it was unusual in that it was linking to an article from the Society for Interventional Radiologists. And they have basically come forth and endorsed a procedure called genicular artery embolization, or GAE. Simply put, that means blocking off blood flow to parts of the knee that, in theory, are causing a lot of pain. And I knew immediately at that point that that meant I probably need to get up to speed on it. So today, I brought in an expert. This is Dr. Connie Hsu, who is one of only 15% of the entire population of radiologists in the United States that is a fellow of the American College of Radiology. That's an honor and distinction that very few achieve. Dr. Hsu is extremely experienced in interventional procedures. She's done embolization not only on the knee for a number of years, going back at least 7 or 8 years, but also other body parts like the prostate, the uterus that she'll talk about a little bit today. Thank you for joining us today. I'm joined by Dr. Connie Hsu, a fellowship-trained interventional radiologist and one of the most experienced in our areas. In fact, she performed the first genicular artery embolization in the Austin area. So, Connie, thank you for joining us today.
Thanks for having me.
One of the sort of reasons this has come up is that your society has recently endorsed this, or the procedure of genicular artery embolization for knee pain. And can you talk about the significance of that?
Well, the Society of Interventional Radiology recently put out a paper stating that genicular artery embolization, according to our experts and multi-specialty experts involved in the panel, feel that should be part of standard care. And they kind of produced an article giving the reasons and the data behind that. And I think we're going to talk a little bit about it today.
Yeah, I think I'm going to put a link to that article in the description. It's a good summary, I think, for those that are trying to learn about it. I am starting to see patients ask me about it, and people say, well, this is a joint replacement channel. Why are you promoting the competition? And I don't see it that way.
Yeah.
And I think it's a useful adjunct, and we have a lot of people that aren't operative candidates. So can you tell me, for this procedure, who in your mind is a good candidate for it?
Yeah. So usually to start with, we get a good clinical history and we look at the patient's x-rays. And so the criteria for good candidates for this procedure are patients that have moderate to severe pain for greater than 6 months, patients that have mild to moderate osteoarthritis on their x-rays, patients that have already done the traditional conservative therapy of NSAIDs, PT, or physical therapy, as well as knee injections for at least 3 months or more. And then patients who are just not ready yet for surgery, or those who are not good surgical candidates.
So I have tried to learn a lot about this and
Yeah, that's great.
dug in pretty deep to it. And in some of the studies I've noticed, they exclude patients that have what we call Kellgren-Lawrence grade 4, which is a 1 to 4 scale. It's just very basic, but those are the most severe
Yeah.
arthritis cases. Do you think they're still candidates for this and could benefit?
Yes, it sort of depends on what the MRI findings show. So if the MRI findings show that the patient has full cartilage defect or have bone marrow edema or abnormality, then I don't think that this is going to be a successful procedure for them. But if they are Kilgram's-Lawrence 4 but don't have those findings, then there is a chance that we can help them.
I had used this before in the setting of occasionally patients with knee replacements will bleed into their knee.
Correct.
They developed a little lesion, and they're hard to get to stop, particularly if they're on blood thinners. And we've seen it'd be very effective in stopping those spots from bleeding without us having to go in surgically and do something. And now it's sort of being used in a situation of relieving pain. In your experience, how did it evolve from a blood-stopping procedure to a pain-relieving procedure?
Interventional radiology has been around for many years, and we get involved when there is bleeding. right? But then what we find when we do treatment afterwards is that there are potential therapies involved. So just like we got involved in postpartum hemorrhage, and then we found that those women that had fibroids, those actually shrunk in size, and then that created the field of fibroid embolization. And so in regards to knee hemarthrosis after total knee replacement, we were already involved in that space, but then the thought process is, well, what happens when patients that have knee osteoarthritis before surgery, can we help them, with their symptoms? No different than prostate artery embolization became evolved from the success of uterine fibroid embolization in women. The thought was like, can we help men with their enlarged prostates? So just like medicine, everything continues to evolve, questions get asked, and the thought process is, how can we help? What can we develop to improve disease process?
It had kind of been utilized in other fields before, and I
Mhm.
think it's important to explain that the term is a jumble of medical words, genicular artery embolization, but basically it means
Yeah.
is the arteries that go to the knee get clotted off or clogged off, if you will, by what are called emboli. Normally, we associate emboli with something really bad, like a pulmonary embolus,
Yeah.
but they apparently you can do it in a controlled fashion that only affects the very small blood vessels and be targeted to the area that we see as a problem.
Correct. So, knee osteoarthritis begins with inflammation starting, and inflammation creates these small blood vessels, what we call angiogenesis. And these new small vessels actually continue that inflammatory process by bringing inflammatory cells and inflammatory factors to that knee joint, causing damage. In addition to that, these small new blood supply, they also stimulate growth of these nerve cells that cause knee pain. And so this combination of vicious cycle, what embolization does is it cuts that vicious cycle by targeting those abnormal new blood vessel supply.
Patients shouldn't fear that they're going to lose circulation to their leg.
No, not at all. So, what we usually do is we go into the artery in the leg with these small catheters, and then we super select the branch vessels, these genicular artery branches that feed that area of pain. And how we detect that is with an inflammatory blush that we see on angiogram. And we go in with microcatheters to reduce just that inflammatory blush. I like to call it just pruning of the blood vessels. And thereby, we leave that trunk of that genicular artery branch completely intact.
And I've read that the size of the particulate material you use is really quite small. It's like
Yes.
100 to 300 micrometers or
Yeah.
so. It's like
So
grains of sand
Yeah, so
almost.
we do like we utilize Embospheres, which is an FDA approved embolic product. And so it's usually 100 to 300 micron of embolic particle size. Embozine, which is another competitor brand, is 75 microns in size. Now in Japan, they use actually a antibiotic called imipenem, and if you sort of agitated in contrast, it creates these microcrystals that produce a temporary embolic agent. They have found that, all these different agents are just as effective. Now, comparison trials are still underway in regards to what's best, but really in Europe and Canada, who have been doing genicular artery embolization for a while now, they have taken Embozine and Embosphere as a indication for MSK embolization now rather than off-label designation. So it's being widely accepted.
So the preference is that they be temporary blockages, not permanent. Is that?
I think permanent and temporary are both efficacious.
Yeah.
The concern about the temporary is that, it may not be as long lasting. But with Dr. Okuno's paper using temporary imipenem, they were able to gain at least, 4 years of treatment response. So we typically will use more permanent embolics because there are patients that have allergies and imipenem at one point in time was not readily available.
Yeah, I know there's some concerns about using an antibiotic and widespread use of that to, with
Yeah.
bacterial
But then there's
resistance.
also the thought process of, like, if we use something temporary, it's not permanent,
Right.
is that better for the patient?
Yeah.
Because if all you wanna do is just cut off that sort of inflammatory blood vessel response, you can do that temporarily. So there's many ways to argue it. I think the data is still pending on that, but really the preliminary data is that they're all efficacious.
A lot of the studies I read, most of them, go out at least a couple of years, and it seems some of the pain relief is fairly long lasting.
Yeah.
Um, but then it does eventually tend to kind of fade away. Is that because of the temporary nature of the particles you're using for emboli, or is it neogenesis, or the
I feel
body's
like
finding a new
that
way
is just
around
that
it? Or
genicular artery embolization is not a cure for osteoarthritis.
yeah, this
Yeah.
disease progresses.
Yeah, so
Yeah.
I think the key thing to tell patients is that this is a procedure that will help to reduce your pain, but it's not gonna eliminate your pain.
And who is not a candidate for this?
So patients who are not candidates are patients that have severe artery disease in the leg, those that have fibromyalgia, patients that have infection, patients that have severe osteoarthritis, like we talked earlier about, with full thickness cartilage defects on MRI, or patients that have bone marrow abnormalities on MRI, patients that have severe knock knee or bow leggedness. Those are mechanical factors that prohibit a good response to genicular artery embolization. And to be clear, when it comes to rheumatoid arthritis, this is not first line therapy.
I'm curious as to why that is. Normally with rheumatoid arthritis, they have a very prolific synovitic response. The synovium gets very inflamed and irritated.
Yes, yes,
But
but
is it because it's so diffuse, or what? Why are they not a
I
candidate?
I feel that why they're not candidates because, I think that many of the studies felt that there was, for rheumatoid arthritis, much more inflammatory component, and they didn't want any confusion. And so, for me, I like to sort of stick with those qualifiers.
Yeah.
And as I said before, first line for rheumatoid arthritis is medical therapy.
And for people with peripheral artery disease or bad
Yeah.
circulation, do you have to kind of be careful there? Do you have to screen people for that?
Yeah, so that's why it comes that it's important to have a good clinical history when you're evaluating patients. So, patients that can't receive contrast, like those that have bad kidney disease, or patients that have severe allergies to contrast despite pre-medication,
And these
those are
are
things.
iodine-based contrasts?
Correct.
Okay.
These are things that you need to obtain when you're getting a good clinical history. And so part of that is seeing if the patient is having claudication when they walk. Then we can do an evaluation of the arteries and see if there is significant arterial disease. And if that's the case, then we can also provide them arterial intervention if need be.
So claudication is a symptom when people don't get enough blood flow. They have pain in their limbs, especially the further away from the heart you go, because they're basically being starved of oxygen.
Correct.
Um, if you do pick that up, do you use a specific type of test? Is it ABIs or
So
Doppler? Yeah,
we have the capability, because we're Austin Radiologic
yeah.
Association, of doing ABI Doppler evaluation, which is the first line screening. And if those are abnormal, then we have the capability of doing a CTA or MRA. And based on that, we will either recommend referral to vascular surgery or peripheral vascular intervention.
Having diabetes, which is often associated with peripheral arterial disease, is
Correct.
not necessarily in and of itself a contraindication.
No, it's
But
not.
if they were developing PAD or having
Exactly.
foot
Significant
ulcers and things like that,
blockage
yeah.
of the arteries in their legs, that's a bigger deal.
What, in your experience, is
Mhm.
the success rate of this procedure?
I feel that this procedure is most of the time successful, 70 to 80% of patients. That goes along with the data that previous, authors have had in terms of reviews. The one thing is I like to stress in regards to durability is that no matter what treatment response you look at for genicular artery embolization or total knee replacement, the key to durability is about avoiding misuse and overuse. And so another factor also is weight loss. I feel that these days with the GP-1 agonists like Wegovy, Ozempic, and Zepbound, those have been helpful to patients in regards to weight loss. Um, but those are key factors in regards to durability for anything.
It's not often I look at the radiological or radiology literature, mostly spending my time in the orthopedic world. But
Same
this,
here, same
one
here.
of the great things about this channel, it forces me to learn, new and different things. And
Yeah,
I'm a big stickler about high quality evidence, level one evidence, randomized controlled trials. But I also think it's incredibly important that there be blinding when necessary and there be placebo controlled.
exactly.
And I have to compliment your field in general. A lot of the studies I looked at were really well designed, maybe a little underpowered, but
Mhm,
meaning they didn't have enough people to make really strong conclusions that were involved with it. But a lot of them are even using sham.
mhm.
And most of the studies are showing a benefit over a sham. Sham means you make them think they're doing it. You do pretty much everything but the actual procedure
Right.
itself. But I think it's important to understand that a lot of people with the sham procedure do see pain relief,
Mhm.
but the procedure itself actually does win out over that. Can you comment on those findings at all?
Well, I think that you and I both know that sham placebo effect has its place. It is there. It's real. But the onus on our society is showing that having a complete embolization when regards to genicular artery embolization has a positive effect and a statistically significant impact in patient recovery.
You bring up a really good point, and uh, there's something called a dose response curve. And
Mhm.
when we're trying to determine causation or is an intervention effective, it certainly helps to have a control group. It helps to have a sham group. It helps to have blinding. But there's other things you can look at. There's signal that when you do more of this, pain relief is improved. That
Mhm.
is very reassuring that the intervention's actually doing what it's designed to do. But that's that dose response. I noticed in one of the studies that when more of the arterial circulation is embolized, then people get better pain relief.
Yes, it's called completeness of embolization. So it's not about just selecting one vessel, it's about finding
The
how
whole
many vessels are supplying that blush and then targeting all of them.
How challenging is this procedure for a radiologist to learn? How technically difficult is it compared to some of the other things you do?
So I think that prostate artery embolization is one of our more technically challenging procedures. And the reason is because the prostatic artery is equal to 16 strands of your hair, and it can come off in a tortuous way. So we have to use, selective microcatheters that will allow us to do that. So genicular artery embolization is much more of a straightforward procedure. It's something that we can all do, and it's in our wheelhouse. So it also has a high safety efficacy factor to it, as many studies have shown.
I, as you mentioned, through most of the studies, there's a very low complication rate. I think maybe one person had a blood clot that was probably not even related to the procedure itself. One of the more common ones I read about was skin discoloration.
Yes.
Can you talk about what that and looks
Yeah.
like?
So skin discoloration is modeling of the skin, particularly when you utilize permanent embolics, but it's a very temporary, minor kind of thing. Surprisingly, we found that by doing ice packs directly before embolizing on the skin, that helps reduce that risk factor.
And is that because it constricts the vessels
Correct.
of the skin so the
Exactly.
emboli can't get to them? They're too
Yes.
small.
Yes, they're too small.
I
So
see.
the reason for the non-targeted embolization to the skin is those little microparticles that we were talking about penetrates to that level. So if you can prevent that penetration with just simply an ice pack to the skin, then that will help reduce that temporary minor procedure complication.
Your society's adopted this or endorsed it in the use of the knee. Do you see this moving into other joints, other parts of orthopedics?
Yeah, I mean, I think in Europe and Canada, here in the States, we've have sort of taken from the knee the knowledge that this is an important thing in terms of cutting off that inflammatory response to then parlaying it to other areas in the musculoskeletal joints, such as shoulder and elbow and even wrist.
So, as an orthopedic surgeon who makes a living replacing knees, and
Yes.
as a patient myself, I had my knee replaced almost 5 years ago now. How do you see this working? Is it going to be competitive? Is it going to be complementary? How do you see the two fields working together on
So
this?
it's not
And
meant to be competitive
yeah,
at all. I see this as something in between conservative therapy and surgery. So I too had knee arthritis pain 4 years ago, and I underwent physical therapy. I had steroid injections. I even did PRP injections. So I was willing to try anything. And thankfully, conservative therapy helped and I got better. But what if it hadn't? I don't think that I'm ready for surgery. And so this would have been something that I would have considered.
in your mind, it sort of fits in, but after the sort of things we talked about on this channel, injections, weight loss, physical therapy,
Right.
anti-inflammatory medicines,
Yeah.
but then potentially before surgery. What about one of the more common use cases I would see for it is we have a lot of people that sadly just aren't candidates for knee replacement surgery.
Yeah.
They're
Or surgical
and
candidates.
and
Yeah.
do you think it has a role there?
Yes, it does. Like we talked about, patients who are just not ready for surgery or patients who are poor surgical candidates. Now, those that are just not ready, I wanted to make it very clear, and I think you saw also in the standards of care position with the Society of Interventional Radiology is that what we have found with genicular artery embolization is that it has no negative impact on the knee, and so it does not impact the patient if they ever decide to have a total knee replacement. So that's a win-win situation for you as a surgeon
Mhm.
because patients who are not good surgical candidates, but you want to have them get help, we can try to help them. And then on the other hand, patients who are not ready to have surgery with you, we can at least temporize things until they get to a point where they're ready to have knee surgery with you.
Do you think there's ever a role for this in postoperative pain control?
Yeah, I mean, some people have been doing it for postoperative pain. I've also treated postoperative pain and hemarthrosis. It just gets challenging with the hardware because you have to, turn the camera different positions so that you can look at all the arteries. So it's just more challenging for us, but it's doable.
One of the procedures we frequently go to when we've just tried everything and they can't have knee replacement surgery is geniculate nerve blocks or ablation. And
Hmm.
that's probably kind of fits in the same place in
Hmm.
the treatment
Yeah,
protocols. But
yeah.
um, can you tell me? And I've seen some of the, there's some, I believe, there's a trial called the Geni. There's the Genesis 1 and 2. And they're actually not only now comparing this to sham, but against kind of proven things like anti-inflammatories, steroid injections. And I believe they're comparing it to geniculate nerve ablation.
Hmm.
And one of the things I was reading is that it looked like this tends to be a little bit longer lasting than geniculate nerve ablation, perhaps. Can you comment on how you see those two treatment options?
Well,
Com-
so just to sort of talk about expectations for patients, I will usually, after procedure, tell patients that they should expect their knee pain to be worse during that first week. And majority of patients at 1 month follow up will have improvement in their symptoms. And then there are some patients who are slow responders, and at 3 months, they have improvement in their symptoms. But that said, no procedure is 100% successful. And so, if for those patients who at 6 months are not showing any treatment response, then I feel it's in my duty to tell them about nerve ablation as an alternative. And then also coming in the forefront these days is also low dose radiation treatment for,
right,
MSK pain.
right. Another thing we need to look into.
It has been sort of utilized and accepted in Europe, and then here in the States, it's finding its place in that sort of middle of the road thing that we were talking about, where genicular artery embolization and genicular nerve ablation fits in between that treatment algorithm.
In your experience, is Medicare covering this? Do patients have insurance that typically covers for this? What does that
So
look like?
so we found the same challenges that we have with insurance when it came to prostate artery embolization that we have with genicular artery embolization. I feel that, having the society produce that paper in regards to standards of care helps provide some of that data point for insurance companies to update their policies. It depends on every patient's insurance plan. If no pre-authorization is required, usually we're able to perform it and there's no issues. If we have peer-to-peer review process required, I find that peer-to-peer, often we come up with resistance because the reviewers have lack of knowledge or their plan update is not
Yeah.
updated to current standards.
It stretches the definition of peer. Uh, we all deal with it.
Yes, yes. I was arguing about a patient of mine that needed a prostate artery embolization, and the person that I was talking to seemed a little bit oblivious to my arguments of why he needed this. And then I asked the person that was doing the review what their specialty was, and it was OBGYN.
Yeah. Yeah. I've spoken to plenty of general surgeons that are retired and want to tell us how to practice orthopedics. So
Mhm.
it's interesting. But in general, let's say in straight Medicare, are they typically covering it for you?
Yes,
And it's
because we do a general body embolization,
okay,
procedure, and so there's no
good.
pre-authorization required, hopefully based on that patient's plan.
But some of the Advantage plans, are they a little bit, they need
No,
usually
but then they
pre-auth?
require peer-to-peer review, and then
Yeah.
that becomes a problem, right?
Okay.
So, but we do offer for patients that have, insurance denial, the opportunity to pay out of HSA or FSA, um, treatment with 40% discount.
I know what patients are going to ask. Does this hurt?
I mean, I always tell patients that after procedure, your knee pain is going to be worse for that first week,
Really?
uh,
Okay.
and then with time, it gets better and better. It's just a response to embolization or cutting off that inflammatory process. But there are some patients that that doesn't happen to. But it's really important to sort of tell patients what
Yeah.
they may or may not encounter after procedure. I want to tell them everything that they may or may not experience, so that's not a surprise.
And if they were hurting a lot after, would you ever allow them to have a cortisone injection during that period of time? Or do you think that's
Well, I've most of the time, if I feel that the patient is at high risk of having significant pain post-procedure, I've nowadays put them on a steroid pack.
like a Medrol dose pack? Okay.
Correct, correct.
But they
If
don't
there's no
typically need
contrast.
opiate pain medication.
No, no, no.
Okay.
I mean, the highest I've given is tramadol.
Do you allow them to take anti-inflammatories, or does the bleeding risk
Yes, they
bother you?
can.
They can?
Yes.
Okay. But it's the knee that would hurt typically, not the groin that they complain
No,
of.
but if they have a groin complication, then that's gonna
Yeah.
be a tincture of time.
But that's rare, right?
Yeah,
Yeah.
yeah.
All right. I'm a patient. I want to do this next week. I'm signing up for it. Um, what can I expect if let's say my procedure's on a Thursday? Can I go to work Friday? Do I need to take a few days off? Am I going to be in much pain? I know there's what we call conscious sedation involved. So, and how long does the procedure take? Is it
Yeah. So I usually have patients come in. This is an outpatient procedure. It's done in the angiography suite with moderate sedation. So you will need to have a ride to take you home. That said, because it's a minimally invasive procedure, you should be able to go to work the next day if you, let's say, you have a desk job or a low impact work. But if you are high impact or doing heavy lifting and so forth, then I usually tell patients they need to be on light duty for at least a week post-procedure.
and that's to protect the arterial puncture site
Yeah, so you
predominantly?
don't want heavy lifting and
Yeah.
then you you pock that little hole that we made in the artery and you
And
have
that's in the groin usually?
yes, and you
Yeah,
have bleeding or hematoma,
yeah.
we don't want that to occur.
And if patients are on blood thinners, they obviously would probably need to come off of them before this procedure or
So, patients that are blood thinners, we typically like them to come off because we want to reduce that sort of minor risk complication of groin site hematoma and bruising. But if they can't be off of it, then, then we will usually try to do a smaller catheter anyway to reduce that risk of bleeding as well as use a closure device.
in closing here, what would you say to patients that are considering this? What's the takeaway they should learn about this procedure?
I think the takeaway is that there is hope when it comes to having that sort of middle of road sort of treatment algorithm between conservative therapy of NSAIDs, which is, nonsteroidal, ibuprofen, aspirin, and physical therapy, as well as knee injections, and then surgery. So, this having this middle of the road treatment option does provide patients with hope. And I want patients to know that in regards to genicular artery embolization, this is about reduction of pain, not elimination of pain.
Connie, thank you for joining us.
Thanks for having me. It's been fun.
So, my final thoughts on the role of GAE or genicular artery embolization are that it's a useful adjunct and it has a role. And I think Dr. Hsu stated them quite well. I don't think it's going to put me out of business. I'm all for something that would put me out of business, but clearly there's still a very strong role and need for knee replacement surgery. We've talked on this channel a lot about the non-operative treatment options, anti-inflammatories, injections, physical therapy, weight loss, amongst others that are proven that have genuinely pretty high success rates. But there comes a point in time when those fail and surgery becomes necessary, or people aren't ready for surgery, or they aren't candidates for surgery. And we're constantly looking for other options for them rather than just say, sorry, you have to live with it, or go get on opioid pain management, which is going to be really not a very pleasant way to live. But I would remind everyone when we talk about joint replacement surgery and the indications, we look at it through two broad categories, the pain and the function. And while this procedure, I think, could potentially help people from a pain standpoint, it doesn't do probably too much for the function side. And they're going to start studying that a little bit more into the future. But there are things like deformity, like instability in the knee, that this isn't going to correct. Only a joint replacement surgery, perhaps some degree of bracing, but generally takes a knee replacement surgery to correct. And for that reason, I think this is a useful adjunct, not a replacement to knee replacement surgery. I'm very interested to follow some of these trials, such as the Genesis 1 and 2, the Geni trials we'll start to compare this to other proven pain relieving strategies we have in joint replacement surgery. That's all I had for today. I hope this was helpful. I'll see you next time.